And the question was, if we had done the physical exam, did a bimanual exam, a speculum exam, did an abdominal exam, if we didn't clinch the diagnosis from that, what other workup might you be doing for her?
I think the role of a blood count, it's not unreasonable to check some blood work. In my experience, if somebody's only had 4 months of really heavy periods, they're probably not anemic, but it's always worth checking, if there's no real reason not to check labs. So a hemoglobin would be useful. A TSH would be useful because thyroid dysfunction can result in abnormal bleeding. And then a pelvic ultrasound is always useful. I send my patients to radiology as well for that. So that's definitely helpful to have.
Is there a stepwise approach? I mean, obviously you look at the patient in front of you, but do you sort of wait for the labs to come back before you ultrasound? I feel like that's always, I shouldn't say always, but in practice, if you see a patient like this, you might order a battery of labs, expect them to come back normal, give them an ultrasound in hand. And I guess the question is like, does every patient warrant an ultrasound? It just seems from the outside potentially kind of invasive and uncomfortable for the patient. You almost kind of want to avoid it if you can, even though I don't think that's necessarily the right thing to do. But I mean, I guess, how are you making the determination who gets ultrasonography, who does not? Sort of, how does that, where is that in terms of helping you triage things?
Yeah, I think this might depend on what your plan is with the patient for, how much you're going to manage this bleeding versus are you going to refer to GYN? I think if you're going to refer to GYN, it is helpful to have an ultrasound, not mandatory, but certainly helpful. And I think if this patient then gets to me, I would probably order an ultrasound if nothing else, very clear has come up from the physical exam. In terms of invasiveness, it generally does involve both a transabdominal and transvaginal scan. The transvaginal probes are pretty small, and I always mention to patients that they have the right to decline the vaginal portion if they prefer. And, in my experience, the sonographers are really good about, showing the patient the probe, lots of positioning and mitigation techniques for managing the discomfort. I don't know what this patient's pregnancy history is, but honestly, most patients who have given birth are comfortable or willing to tolerate the transvaginal ultrasound in the name of potentially getting useful information out of it. So if we have an ultrasound that shows nothing clear, I think it is still helpful to know. So there's benefit to sort of like the negative test here. I think if you or I were seeing the patient and we're making sort of an empiric plan for management, maybe with some medications, it's reasonable to do that without getting an ultrasound first, with the consideration that maybe if things aren't better or things have changed in 3 to 6 months, that an ultrasound is something to remember we haven't done yet.
I was going to ask, do you try to counsel your patients to get the ultrasound done on a particular day of their cycle, or it doesn't really matter?
Ideally, you want to get it done in the follicular phase. So that's the first half of the menstrual cycle after the heaviest bleeding has stopped, but before ovulation has occurred, because that's the time in the cycle when the endometrial lining is thinnest. If it's going to be a scheduling issue for the patient, then I'd rather, have any ultrasound than make a big deal about timing.
I was going to ask, could you talk to us a little bit about sonohysterography, which I may be mispronouncing. I feel like we read some practice bulletins in advance of this, and they were sort of loving talk about how great it was at sort of examining sort of internal topography and that kind of stuff. And it's not something that was on my radar at all, embarrassingly. So is that something that is done commonly in practice? Should we be thinking about that at all, or is that best deferred to the experts?
Even in my world, it's not something that I do personally, and the radiology department at my institution doesn't perform them routinely. So you definitely need to know what your institution offers and, who's able to perform it. So I do have a couple of subspecialty colleagues who can do them, but because they're not readily available to me, I don't routinely do them either. But the idea is that you're injecting some sort of generally saline into the uterus. So you place a catheter through the cervix into the uterine cavity and inject saline often and through that. And then simultaneously, you're doing a transabdominal ultrasound so that you can see the fluid pass through the uterine cavity and then out the fallopian tubes. And it can give you an idea of the internal contours of the endometrial cavity.
And how does that differ from a hysterosalpingogram?
So a hysterosalpingogram is logistically slightly similar. This is generally done in radiology because it's done with under fluoroscopy. So a catheter is placed into the patient's cervix, and they're placed under the X-ray machine, and then some sort of a fluoro dye is injected into the uterine cavity, and a series of X-ray films are snapped. And so they'll inject the dye into the uterus, and then have the patient turn to one side and then the other, and you're actually looking to see if the dye spills out the tubes. So the hysterosalpingogram is technically only designed to check for tubal patency, but often in the process, you can get a sense of the endometrial cavity as well.
So bottom line, we don't need to feel bad that we have not
do
been
not
ordering
need to
these.
feel bad that you're not ordering those. Yeah. I think a regular pelvic ultrasound is perfect. And honestly, if I have a pelvic ultrasound that shows something abnormal, my next step would be direct visualization, meaning like in the operating room. So I usually in my routine, cases would not follow up an ultrasound with a hysterosalpingogram or a sonohysterogram.